So imagine you're going in for what you think is just a routine clinic visit.
Yeah.
Or just a simple cosmetic injection.
Right, something people do every day,
Exactly. But then, minutes later, the patient is in profound shock. I mean, her heart literally stops.
Oh, wow.
Yeah. And she's suddenly rushed into this intense 9-day battle on life support. And the crazy thing is, this wasn't some freak allergic reaction or anything.
Oh, was it?
No. It's actually the terrifying consequence of a needle being off by just 1 single millimeter. Because in the world of aesthetic and regenerative gynecology, we aren't just looking at, standard predictable anatomy.
No, definitely not. We often tend to think of the human body as this, like, static map. A fixed diagram you just find in some medical textbook.
Right, with all the color-coded veins and arteries.
Exactly. But the reality is that our tissue is a living, breathing, profoundly dynamic landscape. And in this highly precise, incredibly high-stakes medical field, the terrain you're working in dictates absolutely everything.
Which is exactly why today we are taking you on a deep dive into this sort of masterclass in anatomical navigation. We're looking at a really fascinating stack of clinical sources and medical guidelines to answer one central, honestly, life-saving puzzle.
It really is life or death, yeah.
It is. We want to know how a clinician have to fundamentally alter their technique, like literally how they angle and drive a needle when treating 2 completely different conditions in these intimate tissues. Specifically, we're talking about generalized mucosal atrophy versus a dense, localized episiotomy scar.
Right, because in this specific part of the body, if you go a millimeter too shallow, the treatment just completely fails.
It doesn't do anything.
Right, but a millimeter too deep, you could breach a massive vascular highway.
Okay, so let's start by exploring that first terrain you mentioned, generalized mucosal atrophy. What is the actual environment the needle is entering when a clinician, tries to treat this?
So clinically speaking, this falls under what's called genitourinary syndrome of menopause, GSM. Basically, when a woman's estrogen levels drop, it triggers this slow-motion global collapse of the tissue's architecture because estrogen is essentially the primary fuel for fibroblasts.
And fibroblasts, those are the cells that build the structural scaffolding of our bodies, right?
Exactly. They're the master architects. I mean, they weave the collagen for sheer structural strength. They lay down elastin so the tissue can stretch and bounce back.
Right, that recoil.
Yeah. And they also pump out native hyaluronic acid to keep the whole area plump and hydrated. So without estrogen to fuel them, the fibroblasts essentially just go dormant. The scaffolding just crumbles.
Wow, so you're left with this incredibly thin, fragile landscape. The barrier is just gone, which I'm guessing means the blood vessels lose all their padding.
Exactly. They lose their protection entirely. The microvascular integrity is just shattered. The mucosa becomes like paper thin. It gets prone to severe dryness, burning, and even microscopic tearing from just minor friction.
That sounds awful. Okay, so if a drop in estrogen causes this slow-motion, widespread architectural collapse across the whole area, what happens when the tissue suffers an acute, localized trauma, like, say, a surgical cut from childbirth?
Right. Well, in that case, the tissue basically panics and overcorrects.
Oh, really?
Yeah, and that brings us to the second terrain, the focal episiotomy scar. Unlike the slow thinning you see with atrophy, an incision from childbirth causes the body to urgently lay down this disorganized, highly fibrotic tissue just to patch the wound.
So it's rushing to fix it.
Exactly. And because it's rushed, it becomes stiff and retractile, meaning it physically pulls the surrounding healthy tissue inward. It completely lacks normal mobility.
Okay, so picture this. If you are a clinician holding a syringe, trying to inject rejuvenating fluids into generalized atrophy, that's kind of like trying to carefully hydrate a thin, dried-out sponge, right? Without ripping it.
That's a great way to look at it, yeah.
But then, treating that episiotomy scar. That sounds like trying to drive a needle into a hard, twisted knot in a piece of wood.
It literally is. The physical resistance of the tissue goes from near zero to just incredibly dense.
Okay, but let me push back on that dried sponge idea for a second. Because if the tissue in atrophy is truly that paper thin, wouldn't a doctor be absolutely terrified of pushing a needle straight through it?
Oh, absolutely.
I mean, if there's no scaffolding left, how in the world do they avoid just piercing straight through into the deeper structures that they really shouldn't be touching?
Well, that fear is entirely justified, and it actually forces clinicians to just abandon standard injection techniques altogether.
Really? So they can't just inject it normally.
No, they cannot just flood the area with product. They have to painstakingly build what we call a shallow matrix.
A shallow matrix, what does that mean exactly?
So they use hand-injected mesotherapy. They're creating hundreds of tiny microdroplets of hyaluronic acid to reconstruct the area, basically millimeter by millimeter.
Wait, why hand-injected, though? Wouldn't some sort of precision machine be better for something so delicate?
You would think so, right? But a machine doesn't have tactile sensation.
Oh, feeling the tissue.
Exactly. The clinician needs to physically feel the exact resistance of the mucosa to know that they are in the correct superficial layer. And surprisingly, to do this, they use very fine, sharp needles, typically 30 gauge, about 13 millimeters long.
Sharp needles, rather than blunt cannulas.
Yep, sharp needles.
Wait, I would think a blunt cannula would be so much safer in fragile tissue. Doesn't a sharp needle just increase the risk of puncturing right through that thin barrier?
It definitely seems counterintuitive at first, but a fine, sharp needle acts almost like a sensory probe for the doctor's hand. As it pierces the surface, it provides this immediate, crisp physical signal.
Oh, so they can feel the exact pop of the layers.
Right, whereas a blunt cannula requires more brute force to push through the tissue. And in a really thinned-out mucosal layer, that pushing can actually cause the instrument to just slip past the delicate planes before the doctor even registers the resistance.
I see. So the sharpness is actually what gives them the control. They can feel the exact moment they enter the target zone without accidentally pushing right through it. Exactly. And the trajectory they use is so critical here. They insert the needle at the steepest possible angle, like almost completely parallel to the vaginal walls.
Wow, almost flat.
Yeah, and they create a grid, injecting just tiny amounts at roughly 1 centimeter intervals. Sometimes they even use a retrograde fanning technique. It's where they deposit the fluid slowly as they pull the needle back out of the tissue rather than as they push it in.
Oh, so it's like painting a new scaffold onto that dried sponge, drop by drop, without ever pushing deep enough to hit the plumbing beneath.
Exactly. They rebuild the biological scaffold across a wide area, but entirely in the shallow end of the pool, so to speak.
Right. But when that needle hits the knot, the dense fibrotic scar from an episiotomy, that shallow painting technique must just fail completely.
Oh, it becomes physically impossible.
Because it's too dense.
Right. Submucosal scar tissue radically alters fluid dynamics. The sheer density of the scar blocks normal diffusion. If you try to create a shallow grid there, the fluid will just hit a literal wall of rigid collagen.
And then what happens?
It just pools, or it violently backflows right out of the injection site.
Right, you can't just put a drop of liquid on a rock and expect it to soak in.
Exactly. So the clinician has to change tactics entirely. They must target the margins, the edges where the scar meets the healthy tissue, and the deep base beneath the scar.
Okay, that makes sense.
But there is a massive challenge here. The scar has distorted the local anatomy. It twists and pulls blood vessels completely out of their normal positions.
Oh, so the textbook map of where the veins and arteries should be is just no longer reliable.
It's basically useless in that specific spot.
The body has basically rewritten its own geography.
Yeah.
So how do they safely navigate that if the textbook is wrong?
They have to rely on raw physical touch. Our clinical sources actually detail that for these specific episiotomy scar injections, the clinician often has to perform them under what is called digital control.
Digital control, what does that mean?
It means they place a finger in the patient's rectum during the vaginal injection.
Oh, wow. I have to admit, that sounds highly invasive.
It is invasive, absolutely. But consider the alternative. The clinician is essentially flying blind in distorted territory. By placing a finger in the rectum, they provide themselves with a physical backstop.
Oh, I get it. So they can feel it from the other side.
Exactly. They can physically feel the exact depth of the needle, verifying submucosal placement in real time.
Because the internal architecture is so mangled by the scar, they literally cannot trust visual cues or standard depth estimates anymore. That is a wild realization.
Yeah.
To bracket the tissue between their hands to know exactly where they are.
It really is the only way to ensure they don't accidentally puncture the rectal wall or hit a major displaced vascular axis. And the reason they go through all this trouble to inject into that specific stiff scar is to unlock this really profound biological process called mechanotransduction.
Mechanotransduction. Okay, I think I know what transduction means in physics, right? It's like changing one type of energy into another. But how does that work in human cells?
Right. So in this context, mechanotransduction is how cells turn physical mechanical force into a chemical genetic response. We're talking specifically about something called the piezo-1 UOPTZ axis.
Okay, let's break that down. Start with piezo 1.
So think of piezo-1 as a microscopic physical pressure sensor embedded directly in the outer membrane of a cell.
Just sitting right on the surface.
Yeah. And when a clinician forcefully injects a fluid, like platelet-rich plasma, into a rigid, unforgiving scar, they are creating intense localized pressure. That mechanical stretch physically pulls open those piezo-1 sensors.
Wait, hold on. You're saying the physical push of the plunger does the healing? Because I always thought the entire point of injecting platelet-rich plasma was for the biological growth factors inside the liquid itself, not the literal pressure of the fluid.
It's actually both, and that is what makes this so cutting edge. The fluid definitely delivers the growth factors, yes, but the physical pressure is what unlocks the cell's ability to use them properly. Yeah, when those piezo-1 sensors get stretched open by the pressure of the fluid, calcium rushes into the cell. This sudden influx of calcium sends an urgent signal to YAP and TAZ.
YAP and TAZ, what are those?
They are essentially messenger proteins waiting inside the cell's cytoplasm.
Okay, so the cell feels the physical squeeze, calcium rushes in, and flags down these messenger proteins.
Yeah.
What do YAP and TAZ actually do once they're flagged?
They travel straight into the cell's nucleus and literally flip genetic switches. They change the cell's programming from build more stiff scar tissue to remodel and heal.
That is unbelievable. The physical tension of the injection is the medicine.
It really is. But all this discussion about distorted anatomy and flying blind in scar tissue, it brings us to the most terrifying part of our sources.
Right, the emergency case we talked about at the beginning.
Exactly. Because you might be wondering why clinicians are so hyper-focused on a single millimeter of depth. Like, what actually happens if they misjudge that trajectory?
Well, the vulvar region isn't just tissue. It is packed with incredibly dense, complex venous plexuses, right? Like massive interwoven networks of blood vessels.
Yeah, and if you miss the intended anatomical plane and breach one of those vascular highways, the consequences are catastrophic.
Which brings us to the case report.
Right.
So a 40-year-old woman goes to a beauty institute, and note, not a specialized medical clinic, but a beauty institute for an intravaginal hyaluronic acid injection. And she receives a massive volume, 27 milliliters of cross-linked HA gel.
Which is a staggeringly irresponsible amount for that anatomical area.
Yeah, I mean, minutes later, she complains of severe dizziness, chest tightness, and just profound sweating. Emergency personnel arrive, and her blood pressure is completely unmeasurable. She is in profound shock.
Yep.
What exactly went wrong with the needle here?
Well, the injector completely failed to find that shallow matrix we were talking about earlier. The needle penetrated deeply, directly into that dense vulvar vascular network. So instead of depositing the gel safely into the tissue scaffolding, they injected 27 milliliters of thick, viscous hyaluronic acid straight into her bloodstream.
Oh, wow. Straight into the vein. And because veins carry blood back to the heart.
Exactly. The venous return carried those HA microparticles straight up into the right side of her heart and then pumped them directly into her lungs.
Oh, my God.
She suffered an acute pulmonary embolism, but instead of clotted blood, her lungs were choked with cosmetic filler.
It's literally like pouring wet cement into a fragile plumbing system.
That's exactly what it's like. The larger particles, anything over 100 micrometers, they acted as physical boulders, just blocking the main branches of the pulmonary artery. And the smaller particles bypassed those boulders, traveled deeper, and completely clogged the microscopic fine vasculature of the lungs. The blood flow simply hit a wall.
So her lungs are physically blocked by this gel. But it gets worse, right? Because the body doesn't just passively accept this invasion.
No, not at all. It launches this aggressive, ultimately self-destructive counterattack. The immune system detects this massive presence of foreign material in the lungs and triggers a severe inflammatory storm. It dumps these defensive cytokines, specifically TNF-alpha and IL-6, into the system.
And how do those cytokines actually destroy the vessels?
They act like microscopic acid. In their desperate attempt to attack the foreign HA gel, these cytokines strip away the vascular endothelial cells.
The lining of the blood vessels.
Right, the delicate protective lining inside the blood vessels of the lungs. So the vessels become leaky, intensely inflamed, and completely dysfunctional.
Okay, so you have the physical blockage of the gel, and now the immune system is actively destroying the plumbing from the inside out.
Exactly, and this causes pulmonary vascular resistance to just skyrocket. Imagine trying to pump water through a hose that is simultaneously filled with concrete and actively dissolving.
That's a terrifying image.
The right side of her heart is pumping furiously against this unimaginable resistance. It inevitably causes acute right heart failure.
And her condition deteriorates so rapidly that she suffers cardiac arrest.
Yeah.
I mean, her heart literally stops.
Yeah.
It takes 25 minutes of emergency cardiopulmonary resuscitation, 25 minutes of violent chest compressions, while the medical team scrambles to initiate VA ECMO.
Right. Veno-arterial extracorporeal membrane oxygenation.
Yeah, and for you listening, think of ECMO as a massive bypass operation for a flooded engine. It's this life support machine that completely takes over for her failing heart and lungs. It pulls the oxygenated blood out of her body, mechanically oxygenates it, and pumps it back in, completely bypassing her own damaged organs.
It really is the absolute highest tier of life support we possess in modern medicine. And the most terrifying aspect of this case is that because the HA gel had spread into the terminal branches of her pulmonary arteries, no medication could help.
Really nothing.
Nothing. You can give clot-busting drugs for a biological blood clot. You cannot dissolve 27 milliliters of cross-linked cosmetic filler.
So the medical team just had to keep her alive on the machine and wait for her body to slowly, agonizingly clear the massive inflammation on its own.
Yes, it took 9 days. 9 days on ECMO, utilizing targeted temperature management.
Which is cooling her body down to a state of hypothermia, right? Just to slow her cellular metabolism and protect her brain from permanent neurological damage.
Exactly. And miraculously, she survived and fully recovered her neurological function. But she spent nearly a month in the hospital because an injector missed their depth by a fraction of an inch.
Wow. After hearing a nightmare scenario like that, you're probably wondering how the legitimate experts, the highly trained clinicians, ensure this never happens to their patients. What are the fail-safes they use to keep that needle out of the bloodstream?
Well, the primary fail-safe is a strict, absolutely non-negotiable protocol called aspiration. Whenever a skilled clinician is working anywhere near these submucosal vascular networks, whether they're tiptoeing around the delicate periurethral plexus and atrophic tissue, or trying to avoid the mangled, distorted vessels near an episiotomy scar, they must aspirate.
Meaning pulling back on the plunger of the syringe before injecting a single drop.
Yes. Once the needle is placed at the target depth, the clinician gently pulls back on the plunger. If the tip of the needle happens to be sitting inside a vein, the negative pressure will pull blood into the syringe. The clinician sees a flash of red.
Which is an immediate abort signal.
Absolutely. Stop, withdraw, apply pressure, and reposition. You only push the plunger forward if the aspiration is completely clear. That single 2-second action is the firewall between a successful treatment and a catastrophic embolism.
It's so simple, but so critical. And what about the tools themselves? Because earlier you said they use sharp needles for the shallow atrophy to get that tactile feel. Do they use those everywhere?
No. Tool selection is highly dynamic. If a clinician knows they must go deep, specifically into highly vascular areas or around an unpredictable scar base, they will switch away from sharp needles and use specialized microcannulas, usually 27 gauge or 30 gauge.
Right, because cannulas are completely blunt at the tip.
Exactly. While a sharp needle will slice right through a vein wall like a hot knife through butter, a blunt cannula minimizes shear stress. If a microcannula encounters a blood vessel, the blunt, rounded tip will generally push the resistant blood vessel aside, gliding past it rather than piercing it. It drastically reduces the physical risk of entering the bloodstream.
So the grand takeaway here is that the difference between a life-changing regenerative treatment and an absolute medical disaster isn't necessarily the hyaluronic acid or the platelet-rich plasma in the syringe. It's the provider's profound mastery of trajectory.
Absolutely.
It's their ability to read the terrain, knowing when to build a shallow matrix in a dried sponge, when to navigate by touch around a twisted knot, and how to stay out of the vascular highways entirely.
It really requires a profound millimeter-level respect for the human body.
We have covered some intense ground today. From the microscopic structural collapse of vaginal atrophy to the dense, unpredictable terrain of episiotomy scars, and finally to the incredible life-saving interventions required when the body's internal plumbing is breached.
Yeah, and we also uncovered that fascinating mechanism of mechanotransduction, where the literal physical pressure of the injection forces cells to rewrite their own healing instructions.
Which actually leads me to a final thought I want you to mull over long after this deep dive ends. Because we learned today that a physical scar-like from an episiotomy radically changes the actual pressure and mechanical environment of the tissue. It alters how fluids flow and forces cells to signal each other differently through that piezo-1 pathway.
Right. It creates an entirely new biological reality in that specific spot.
Exactly. And if a visible scar from childbirth can so completely rewrite the microscopic physics of a targeted medical treatment, you have to wonder, how might all the other hidden internal scars you carry from past surgeries, or torn ligaments, or chronic inflammation, be silently redirecting the flow of medicines, nutrients, or even your body's own natural healing factors, without you ever even knowing?
It makes you realize we could be treating our bodies based on an internal map that no longer even exists.
Because at the end of the day, human tissue isn't just a textbook schematic. It is a living, adapting landscape, and navigating it is an absolute art form. Thanks for joining us on this deep dive.